Okay, so let's start with the first aliquot. 68-year-old female being brought in by ambulance due to a fever that was recorded at home at 38.9 and shortness of breath. The daughter's an ICU nurse and she's been recording her mother's blood pressure, and the systolic has been around 70 to 80. She goes on to mention that her mother's been in and out of hospital. Initially, her symptoms were like a chest infection, but now it's like a sort of general decline, on-off fevers, reduced appetite, as well as a pronounced weight loss, roughly like 2 stones, across 8 to 10 months. Her mother's also complaining of like generalized pain all over. Recently, she mentions that she's noticed her mother's newly confused, and that's the end of that first aliquot.
Oh my gosh, that's such a really rich aliquot with so much acuity and chronicity. So, Lyra, how are you putting this together? What are your initial thoughts?
Yeah, my first reflection is that it all started quite interestingly with basically with the picture of acute infection progressing to the septic shock. That was my type 1 thinking. But the interesting thing is that we have a subacute inflammatory tail to this syndrome as well, which still makes me want to prioritize infection causes, but more so of an atypical ones or potentially recurrent typical ones. But also keep more proximately to me the another causes of inflammation like autoimmune diseases and malignancies. Yeah, that was the first reflection. And it's interesting that we have one localizing sign being shortness of breath and previously mentioned symptoms of chest infection, which kind of is curious. I would love to know more like in details, what does the symptoms of chest infection mean? What exactly was the patient experiencing? Was this just a cough, which can be localized not necessarily to the lungs itself? And the shortness of breath in the setting of this decompensation can be in my opinion, like misleadingly localized because it can be like a secondary source of metastatic infection in this patient or just a reflection of systemic inflammatory syndrome with ARDS going on here. So I wouldn't necessarily anchor on the lungs being this primary source of disease in this patient, and would like to know more about the flavor of the infection and what's going on here. And yeah, what do you
Yeah,
think?
I'm right there with you. I think that I think we are dropped into chapter 13 of a story, not chapter one. And I say that because of all the reasons you said. There's an hectic, acute component that is life-threatening right now. But weight loss is not immediately life-threatening. Weight loss implies subacute to chronic disease. So we are solving a subacute to chronic disease that either has progressed so seriously to fall off a cliff or has been punctuated by a superimposed severe issue. So I think our first few chapters of disentangling cannot go back to chapter one. We have to stay in chapter 13 to keep the patient alive. And so I think we have to first figure out the mechanism of the shock. 70% of it is distributive and most morbidly, however, cardiogenic. And then disentangle this to then go all the way to chapter one. And chapter one, I think, is trying to figure out why has this patient lost weight. And I remember we had a nice reflection, you and I, about a weight loss localized versus systemic. And I'll just share the very simple notion that weight loss is in the vast majority of people a multifocal, radiographically positive disease process. And the best way to illustrate that is to remind people that the most common cause of weight loss is multifocal metastatic cancer, but it can be from multifocal metastatic infections. So the probability that this patient has widespread positive radiology is very, very, very high. But that'll be the second phase of figuring out what that radiology means. I think the first phase is why is she in shock with a nod to septic shock based on the inflammatory features that she has. All right, Pamadi, Mike, to you.
Great. So let's delve in some previous chapters. So looking at her past medical history. So a glimpse into who this patient is. She's originally from Zimbabwe, and she's meeting her daughter on a visit, and she's been in the UK since August 2025, and we are seeing her in November. In Zimbabwe, she lives in a district city sort of area. Previously, she used to work on the farm, but now she's a tailor and a crocheter. She doesn't drink alcohol. She's a non-smoker. There's no significant surgical history. Um, but the daughter mentions that in Zimbabwe, in February time, she was admitted to hospital and she was treated for a chest infection there. And then she was discharged home, but there was no like formal diagnosis. Since being in the UK, she's in and out of hospital, like I mentioned previously, and her last admission was a month ago, and she was in for a few weeks. She came in with similar symptoms like shortness of breath, reduced mobility, and low hemoglobin. And so they did a workup for this. They did a CTPA to query like pulmonary embolism, and that was negative. They did a CT abdomen pelvis. Again, there was like a nodule on the liver, but nothing too significant. They did hematinics as well. And they also got a sputum MCNS, and that grew Pseudomonas. And they treated her with ciprofloxacin and then so discharged her home. They said we'll do outpatient stuff, the outpatient MRI, outpatient colonoscopy. And they also did a CT head, and that was negative as well for the confusion at that time. Um, Besides that, there's no other past medical history. She's normally fit and well female. Um, and I will end there.
Very intriguing. Thank you, Pamandeep. Such a clear sense of who this patient is and what she's been going through. Lera, what are you thinking?
Yeah, I'm thinking that this patient is really vulnerable and both systemically with the kind of endemic tail that she's from Zimbabwe, that she potentially got exposed to some endemic infections there, which we certainly need to keep in mind. Also vulnerable by exposure, that she's a farmer, which doubles her vulnerability and exposure to some certain infections as well. And she's also vulnerable locally, namely her respiratory system, because this like recurrent chest infection, recurrent inflammatory chest syndrome sounds quite interesting, which makes me think that potentially, basically, this is either not an infection at all, and we were just treating the wrong thing because we have wrong diagnosis, or it was infection, but it's atypical that we not using the right drugs to treat. Or potentially, we were treating the infection, but there is also persistent local vulnerability, like, for example, lung cancer that is causing post-obstructive pneumonia of some sort. So I would be really focused on the local vulnerability in this patient. What exactly is that is causing the recurrent nature of the syndrome? Yeah.
Yeah, I'm right there with you. I think that yeah, there's a lot of information to sift through, and I think you're picking up on the key aspects of it. Um, uh, my mind is really not set up to be able to dissect this information in a more productive manner until we see what's before us. And there's many layers to that. There's so much data that we accumulate in modern medicine that it's hard to know what's relevant and what's not relevant. And I also think that the inter-hospital reliability of information is so variable. And it's not uncommon that our surgeons feel differently than other surgeons, our radiologists feel differently than other radiologists. That for me, I don't know what to do with this information, but to say that, gosh, it doesn't provide a clear answer. And so, like you, I'm just going to go back to her symptoms, and I'm really interested to see what she's like on exam to make more progress. But I think I would probably want to collect our own entire data set and then cross-examine it with a pre-existing data set. Um, because right now, gosh, all I can tell you in earnest is my entire mental model of her is completely blank. I think she couldn't have anything or have had anything and might have been overlooked or overemphasized. Um, but it's hard not to ignore how much respiratory signal we're getting, both in terms of her symptoms and in terms of her very overt radiographic findings. So maybe we can see what she looks like on exam to begin to tie the present to the past and not be over anchored to the past. I should say one quick learning point is that it is very unusual to find Pseudomonas in the sputum culture unless the patient has had extensive hospital exposure or has structural lung disease. And so the latter, both are probably true in her, but this is not a finding to be ignored. It's a very, very powerful finding of how hard her life has been or how ill her lungs are. All right, Pamandeep, Mike to you.
Okay, perfect. So let's look at this lady. So we see her in resus. In terms of her vitals, most of them are okay. Her blood pressure is 81 over 50, and she's slightly tachycardic. Her heart rate's 113. She seems really frail, severely sarcopenic, slightly dry mucous membranes. She's a bit sleepy, but she's arousable and she's following commands. There's bi-basal crackles anteriorly in the lower zones, but nil else. And there's some sort of like hyperpigmented rash on her elbows, her palms, and her soles. So I'm quickly going to share the picture of that and hopefully you can see it. Okay, can you see that? Yeah.
Yes, yeah.
And once you sort of look into that, then I'll go on to give a bit more information, if that's okay.
Yeah, Lera, what do you think?
Yeah, it looks quite interesting as the fact that it's hypopigmented makes me think that makes me want to think about the evolution of the rash, that potentially there was something more ulcerative, more damaging there, and it's just the scarring tissue that we see that doesn't have the melanin, and that's why it looks hypopigmented. Another thought is that, yeah, potentially there can be like autoimmune destruction of melanocytes, but doesn't really fit the diagnosis. And infiltration, it's another cause that I think that could cause hypopigmented lesions. Yeah, I don't yet know how to connect this with this inflammatory syndrome that the patient is experiencing, but this is certainly an interesting finding.
Yeah, I'm right there with you. I think you just highlighted the downside of having a hypopigmented rash is it can be a manifestation of any dermatitis in its healing phase. And so it loses its diagnostic signal because it can mean that something was there and now isn't. I think it's interesting to see that where it's happening, and it seems to be happening on pressure points, and whether that's a reflection of her hospitalization or a reflection of the problem of pathogy. Very, very symmetrically distributed. And yeah, I'm not able to make much more progress out of it now, but I think when we revisit her visceral fingerprint, the rash may be a clue to help us tie it in together. Interestingly, it doesn't seem to be nodular or deep. It seems to be really at the surface. And so it's going to be interesting to ask ourselves if this is a helpful clue rather than a distractor. How does a surface skin issue marry with a visceral systemic disease? And I think that'll be an interesting intellectual exercise. It's very easy to be confident that a deep skin process is related to a systemic disease by the spread of the systemic disease to the skin. An example of that would be nodular skin metastases or erythema nodosum, so on and so forth, which are nodules and very deep in the skin. The connection of a superficial skin process to the systemic issue is often that there is none. And here that connection might be just pressure points. But often through the secretion of a substance that mediates the communication between a systemic disease to just the tip of the skin rather than infiltrating through it. So yeah, I think that's the only sort of leap I can make is either this is a complete distractor or the skin and the body are talking not directly through the presence of the systemic disease in the skin, but rather indirectly through a substance like a cytokine or an unrecognized paraneoplastic tumor factor.
Okay, perfect. So continuing on with this. So um, she had previous like tests done in her previous admission, and I'll rattle through a few of those. So she had a malaria screen done that was negative, TB cultures pending, but the AFB was negative, syphilis done that was negative, HBV, HCV, HIV not detected. She had urine culture, respiratory, all no growth. She had an autoimmune screen negative, a connective tissue disease screen negative. And then in terms of her bloods now, her hemoglobin's 76 and her baseline's roughly around that area, so like 80 to 90. and it's normocytic. So the MCV is 84, which is normal. The rest of her FBC is normal. Her Usenease normal, liver function tests normal, CRP is 8. And then they also sent off a film, a blood film, which says isolated neutrophils, occasional polychromatic red cells noted, but nothing else. She did have a blood culture sent as well because of this sort of fever she was having. And one of the two bottles grew staph pentyncoferi, which is a gram-positive cocci. Um, and then others tests that they sort of threw out as well. C3, C4 normal, um, CK normal, serum IgG slightly high at 27, normal 16. IgA is 5, normal's 4, but IgM and uric acid's normal. Um, I could stop here because I know it's quite a lot, or I could give you the chest x-ray that we did as well.
Whatever you want, my friend. You're such an expert. What is your instinct telling you?
I think for more progress, I think the chest x-ray is quite helpful.
Okay, let's do it.
Yeah, okay. So let's share that. Um, okay. Let me just put this one down and open it up again. Can you see this?
Yes, we can.
And just for clarity, so this is in August. So when she first came to the UK, and then these last two are like a few days apart. So this is on admission in recess, and this is like maybe a few days after.
All right, Lera,
Yeah,
what do you?
the progression is definitely there. And um, yeah, I don't see any obvious tracheal deviation or pleural disease. Or my mind straightly goes to the haziness in the lungs parenchyma that is bilateral and diffuse. And it's not quite, I don't think the chest X-ray does it a lot of kind of value to this. I would definitely want CT chest to characterize this more. Is this GGOs? Is this nodules that are diffused? If nodules, then what is the distribution? I think the CT chest would be really helpful here. Another thought that I have is that the mediastinum looks kind of weird.
Hmm.
And I'm not exactly sure what is contributing to it. Is this a cardiac silhouette? And potentially the cardiac problems are contributed to the shock, especially with this narrow pulse pressure that we have. But what I wouldn't want to miss is like things in the mediastinum, like mediastinal lymphadenopathy or potentially mass here or some inflammatory infiltrates. Yeah, so the tension that I have is that I would want potentially CT chest without contrast for the lungs and with contrast for the mediastinum to assess um, the whole picture of the disease. I think you're
Rabih,
muted.
muted.
Oh, oopsie. Wow, sorry. Wow, you're perfect synergy. Thanks, guys. Yeah, I'm right there with you. I'm struck by how wide the mediastinum is, and thankfully we don't have to grapple with the tempo of the disease because we see that this is progressive, subacute progressive mediastinal widening. And I say that because mediastinal widening can be a distractor. It can represent a large aorta or a chronic aortopathy or even enlargement of the pulmonary artery, which of course is diagnostically very interesting. But here we literally see the mediastinum get wider and wider and wider and wider, which tells us that a more subacute process, a space-occupying process is happening. And so, yeah, I think the value of a CT chest is through the roof. You can also see in the latter X-ray an important marker of the severity of the illness with the presence of a feeding tube through the esophagus into the stomach. And so that tells us that she is not having organ failure, and that organ failure is essentially nutritional support. It also tells us that her GI tract is working very well enough for people to feel comfortable at least trying to feed her. And so that's an interesting paradox as somebody so sick and so hypotensive and losing so much weight, yet able to receive food. And so it makes me wonder it might reflect the quality of her care and good nausea control and good appetite stimulation. It does, however, reduce the chances that there's something serious happening in her abdomen because the ability to eat and to sustain nourishment and to have a functioning GI tract. And of course, don't get me wrong, it's not impossible, but I do find the presence of a feeding tube here illuminating. Um, so yeah, I think a CT chest with contrast to what will probably shed a lot of light on this case.
Okay. So I'll give you the formal read really quickly, just of the chest X-rays. So exactly kind of what you guys said, to be honest. So there's interval increase of the bilateral diffuse airspace or pacification. There's no pleural effusion. These findings are likely to represent some sort of pulmonary congestion, and there's some mild cardiomegaly. That's all they mentioned. So Lera, like you said, we spoke to RESP and they were really keen to get a high resolution CT. And their top differential for them at that time was, could this be sarcoid? And they wanted us to send ACE levels, to do Lyme serology, and also to do an ECG and an echo, because they were really worried about infective endocarditis. And so we did do a CT, which I'll now share with you. It's coming all thick and fast, so I do apologize. Okay, so can you see that? Let me
Yes, we
just
see a video. Yep. Mhm.
okay, let me just quickly play it then.
Oof. Mm.
just let me know if you want me to replay any part or
Yeah,
the
maybe yeah, maybe you can play it one more time. Thank you. Mm. Fascinating. Wow. All right, Leo. Wow, you're interpreting a lot of imaging today. I love it. What do you think?
Um, yeah, I think that I didn't see any obvious tracheal deviation. My focus was on the lungs at first, and I saw bilateral diffuse granulus and consolidative opacities. To me, it looked more so prominent in the upper lobes rather than in the lower lobes, although we didn't see fully the lower lobes of the lungs. In terms of the mediastinum, I didn't see any huge mass. To me, it looked more kind of anchored on the cardiac silhouette. I didn't see any additional abnormalities in the mediastinum,
Yeah.
and also mild bilateral pleural effusions were there.
Yeah, superb. I think that yeah, maybe I can just ask you a few of all the things you just mentioned, what do you think is the center of your analysis of this case?
Oh, I would say definitely the lungs.
Yeah. And then I think within the lungs, you mentioned the GGOs as the major abnormality. So maybe we can just take a moment to think through that. So when you're handed the word GGOs, what thoughts start to cross your mind?
Yeah. Um, I love to think of them like as Maddie was teaching us, as that there is something basically partially filling the alveoli, and you can go in any kind of direction. What can be filling the alveoli? The most common cause I think it can be water, and as physicians that were working with polyp, I think we're thinking about the cardiac decompensation, pulmonary edema, and yeah, I wouldn't expect it to be so inflammatory, but definitely could be contributing to this presentation. In terms of what else can be there, it can also be blood, and not every DH presents with hemoptysis, and especially with some anemia that we have here. This is a thought that can be still on the table, although it doesn't look very markedly like the EH picture on the CT. I would expect more central rather than peripheral GGOs in such cases, and relative sparing of the abscesses in contrast to what we see here. It could also be pus, so potentially inflammatory process going on, and it can be of any etiology, either infectious or just sterile inflammation going on in the lungs. In terms of non-liquid things. It can also be cells that could be filling the alveoli, and also some substances like protein, for example. Interesting thing at this is that with such extensive disease in the lungs, the saturation seems normal and the respiratory rate doesn't seem too high. So not kind of disproportionately worse on the imaging than on the vital signs.
Absolutely superb. I have nothing to add to your analysis, and I think it's time we play a little game, lighten the mood a little bit, huh? So I'm just going to tell you what I mean about the definitions of alive and indolent. Okay. So alive means that that the entity has replicative potential, infections and cancers. Indolent means it doesn't. My favorite disease in the world, as you know, is gout, and that does not have replicative potential. Autoimmune diseases don't have replicative potential. So if we take all the possible findings on a CT chest of an infiltrate, and the three possible findings are ground glass opacities, consolidation, or nodules. And if you were to take ground glass opacities, compare it to the nodules and consolidation, and put them on a spectrum of which pulmonary infiltrate finding is more indicative of a physiology that is alive or a physiology that is indolent. So let's just take ground glass opacities and consolidation for a second. If you were just, Lera, handed a case of somebody who had a focal consolidation, what would you say is the most common cause of focal consolidation?
I would say probably pneumonia.
Yeah, infection, right? Something that is alive. What if you were handed a case of somebody who has multifocal nodules?
Hmm.
What do you say is the most common cause of multifocal nodules?
Here, I think for us is TB.
Yeah, alive. Alive and well. What if somebody has diffuse ground glass opacities? What do you think?
Yeah, pulmonary edema that is inert.
Yeah, indolent. And here's the beauty and the paradox and the simplicity of the next steps. You have a consumptive process causing the patient to lose 2 stones, which is my favorite new term. I'm learning that it's about 10 kilograms of weight loss. And yet, the marker of that loss in the chest is ground glass opacities, which is essentially, no matter what it is, it's mild inflammation at best. So that's the paradox. Most of the time, when you have a hectic syndrome that involves the lungs, that is consuming the patient, you will see either multifocal consolidations or nodules. And so this paradox is very, very powerful. And for those of you who are interested on reflecting it more, I'll just take you back exactly 7 days ago when Ravi presented a case of a metastatic renal medullary cancer. And the initial read of the CT scan was that the patient had ground glass opacities and mediastinal lymphadenopathy. It was very easy to be like mediastinal lymphadenopathy and cancer easy. How can cancer cause ground glass opacities? And the answer is it cannot, essentially. And the overread on the CT scan, as evidenced by the PET CT they got, was actually those were nodules that had a little bit of ground glass around them. So just to illustrate that point, that when you put these infiltrate findings on a spectrum of activity and replicative activity, the ability to divide and consume, ground glass opacities is at the bottom of the list. The only thing that's more lower than ground glass opacities are the classic fibrotic changes of interstitial lung disease, where you have honeycombing, reticulations, and traction bronchiectasis. This patient has a little bit of traction bronchiectasis, but has ongoing disease activity as evidenced by the ground glass opacities. So the paradox is often a source of friction, but I would say it's a profound diagnostic clue of how can you have ground glass opacities consume the patient. So I think I just wanted to vocalize that tension. And we can certainly make more progress out of everything else, but I'm curious what questions or reflections you have on that paradox. Lera?
Hmm. I would just mention like if we assume that ground-glass opacities are inert and potentially not by itself etiologic or causative for the patient's consumption, what are the places you would potentially look at
Yeah.
that could cause secondary ground-glass opacities?
Yeah, I think that's that. I mean, I think that's the power of that is that most of the time they are really inert and not indicative, but there's a few exceptions to that rule. Um, and I think if you just approach the ground glass opacities and say what infections are associated with ground glass opacities, none of them cause chronic disease, as we're seeing in this patient. There are mycoplasma, chlamydia, so on and so forth. What cancers cause ground glass opacities? There's only one. It's lipidic adenocarcinoma of the lung, and usually causes consolidations by this point. And so I think this is why this is now, I think, a case, a very strong case for autoimmunity. Because if you are going to have ground glass opacities consume you, it's not going to be from a disease that has replicative potential. It's not going to be from a cancer or an infection. So for me now, I'm like, what autoimmune diseases do I know of that can consume somebody and can present sneakily in the lungs? So could be that actually the ground glass opacities are the acute superimposed infection, and we're taking too much out of them. And when we scan her belly, we'll see a large liver tumor. That's very possible. But if the ground glass opacities are actually a marker of the disease process that is consuming her, the only possibility is it's an autoimmune one. And so, which autoimmune disease, I think, is the question of which autoimmune disease causes the pulmonary findings, maybe even the elbow starts to become a little bit more relevant. But that's the progress I'm making is what if we scan our belly and find something that's easily explains our weight loss? Then these ground glass opacities are probably a virus. But if they're part of the disease process, autoimmune, autoimmune, autoimmune. And that's the power that you can make because you are skipping over infections and cancers with just the CT chest. That's how powerful it is. You have to be careful. Maybe it's not actually the core problem. Maybe it's a distractor from an acute viral process. But if we take for a moment weight loss plus ground glass opacities, autoimmune, autoimmune, autoimmune. Yeah.
Yeah, another interesting thing that I noted is
Yeah.
how disproportionately well the labs are to the state of
Yes.
the patient that we're seeing right now.
Precise.
There's
Precise.
no impaired renal function, liver looks okay, even inflammation is not going haywire, and just an anemia that was expected. Yeah, it's
Yeah.
so restricted to the lungs. That's interesting.
Agreed. Agreed. And then if you take that leap of faith and say, well, you know, the lungs and maybe even the skin, especially since it's symmetric, and now you're invoking the possibility of a systemic disease. I'm really curious if you were to apply that filter of what autoimmune diseases can affect the lungs, the skin, and have such a wasting phenotype. What's the thoughts start to cross your mind?
Hmm. I think many of the autoimmune things can feature the lung syndrome, but not predominantly the lung syndrome. They would
Yeah.
be allowed anywhere else. And what I'm thinking about is potentially the vasculitides
Beautiful.
that can cause this, and also some myositis subtypes that can cause prominent ILD with
Yeah.
hyperinflammatory phenotype. And with
Beautiful.
some muscle wasting, potentially it's not only the general inflammatory syndrome, but also something in the muscle
Yeah.
contributing to the muscle atrophy.
Absolutely superb. If you're diagnosing an autoimmune disease in somebody who's 68, there's only two ones, vasculitis and inflammatory myositis. All other autoimmune diseases are diseases of younger people, lupus. Sorry, I should also say rheumatoid arthritis can also be featured, but rheumatoid arthritis is usually clued by symmetric polyarthritis. So yeah, for me, I'm really, really worried this case is one, and is one of those two possibilities. And if it's vasculitis, then the ground glass opacities are blood. And if it's inflammatory myositis, then we have an interesting paradox. How can you have an inflammatory myositis with no muscle weakness and a normal CK? Um, uh, and maybe you can teach on that entity. If you're just beginning your journey in medicine, you might say, wait, how is Lera saying inflammatory myositis with a normal CK and normal muscle tone? What do you think?
Yeah, it's such a cool entity, which is called amyopathic dermatomyositis. And basically associated with two subtypes, either MDA5 or antisynthetase syndrome that has a prominent lung feature, even that can be even so prominent that it completely obscures and consumes the muscle features of the disease. Yeah.
Yeah. Absolutely superb. You don't need me to be here. My only job, I think, really, Lera, is just to show you how we had such little to say initially. We flew through the first four aliquots. And that's, I think, wise because you're waiting to see what finding will give you clarity. And I would love for all of you to really just take all these lung infiltrates and think about them simply. Nodules, very active, infection, cancer. Consolidation, very active, infection, cancer. Ground glass opacities, sleepy. And if you have sleepy and 10 kilogram weight loss, whew, very narrow differential diagnosis. Now, last piece of advice, if you have a very narrow differential diagnosis based on two findings, weight loss and ground glass opacities, maybe you're not solving the problem the right way. And maybe there's a hidden secret somewhere else that you don't want to overlook. All right, Pavandeep, I think that was a 10-minute ramble. We'll hand you the mic for the next round of data.
Such beautiful discussions. I hope you were there at my hospital at the time. But okay, so a quick read of the CT, which you pretty much did anyway. So patchy ground glass opacities, suggestive of a superimposed infection or inflammatory process on a background of possible interstitial lung disease. Small bilateral pleural effusions, associated with compressive atelectasis, likely reflecting pulmonary congestion or fluid overload in the setting of cardiomegaly. A few of other bloods started to flow in. So ANA negative, gastric parietal cell negative, anti-smooth muscle cells negative, mitochondrial negative, HMG-CoA IgG antibody. Didn't know what it was, but that's negative. Hematinics are fine. Her TFTs are normal. ESR 116, that's high. Her ACE was normal. Her LDH is 411, which is high. And so this is the first time I get to see the patient during the night. And the nurse calls me and she says, this patient keeps spiking her temperature. Come and see her. I was actually bamboozled. I had no idea what to do. So I just took my senior along with me. And we note that she's now on 2 liters of nasal cannula. She didn't need any oxygen when she was in resus. There is proximal muscle weakness. Her ABG shows type 1 respiratory failure. She's now saying I've got progressive swallowing difficulty. And so we were worried. We were wondering whether we should throw antibiotics, whether we should hold the antibiotics. And so we spoke to ID. And ID says she's got no long lines, there's no PPM, there's no prosthetic device, there's no grafts. The blood culture is likely just a skin commensal. There's no clear source of infection. Her CRP is only 7 or 8. Just don't do antibiotics. Just wait. Hold off. And I'll stop there before we then consulted the room.
Oh, wow, fascinating. Yeah, Pavandeep, you're bringing the story to life. I feel like I'm right there in the ICU with you. Lera, what are you thinking?
Yeah. We seem to have hyperinflammatory syndrome now that features the lungs and potentially the muscles. And another thought that I have, if the muscles are so dried out from the systemic inflammation been going on for such a long time, potentially there is no CK left to be spread into the blood, even if there is active muscle destruction. I've never seen this, but just theoretically can happen. Another thought that I had is that I would really want ferritin level in this patient because what I wouldn't want to miss is HLH, and especially since we have hyperinflammatory syndrome with anemia, which I'm not so confident enough. I mean, we have anemia, it can be chronic, but it's always helpful to check out if there's any acute changes. And even in the previous aliquots, when Pavandeep was sharing the peripheral blood smear findings, I thought that I heard some polychromatophilic red blood cells, which are the very early types of red blood cells. And either it's a cool pearl that I learned from you, either there is something peripheral destruction in these red blood cells causing the bone marrow to work really hard, or there's something pushing it out. And yeah, this to me is another rings another bell to the possibility of very aggressive hematologic complications going on in this patient as well. Although the high ESR talks against that, I usually expect CRP being more than ESR in the setting of HLH. Yeah, but certainly very concerned about this patient.
Yeah, like I'm right there with you. I think it's it's hard to imagine that an ICU team called at the bedside is the first team that detects the proximal muscle weakness, but I will tell you that's not uncommon. When patients are cachectic and frail and really, really ill, we assume that there's symmetric cachexia, and I commend you, Pavandeep, for doing this exam because in addition to the proximal muscle weakness, you have also what sounds like oropharyngeal dysphagia. And I'm now looking back at that feeding tube, and I now thinking of, gosh, what a profound clue in retrospect that might be that the reason she has a feeding tube is because she may not be able to swallow. And that is one very elegant solution to the idea that somebody's sick but can still eat as long as you bypass their pharyngeal muscles. And whenever you have proximal muscle weakness and oropharyngeal dysphagia, you're in an emergency. The reason for that is that now you have such severe neurological disease that you are now no longer able to protect your airway. So, dysphagia is one of the deadly Ds of neurological disease, with dyspnea being the other one, dysphonia, and diplopia. When these occur, your neurological disease is at a really severe end. And there's very, very few neurological diseases, if any, that affect the lungs in a direct way than the inflammatory myositis. So, quite frankly, I think that I'm really glad that Pavandeep calls rheumatology, and I would suspect that this patient will likely benefit from empiric treatment because the data required to confirm an autoimmune disease is often delayed. So I'm thinking right now, Lera, that the only way to potentially save this patient's life is to empirically treat her for an autoimmune disease based on what we have so far. But I know we only have 8 minutes left, so let's hear what Pavandeep did, and we can reflect on that later.
Okay, great. So Room did come, thankfully, to save us. And they started to really put things together. So she looks frailed, healed Gottron's rash on elbows and knuckles, V sign, a faint shawl sign, Holster's rash, no Raynaud's, ulcers on the thighs and necks. Sorry, or the knees, sorry. Progressive proximal muscle weakness and neck flexor weakness. No evidence of mononeuritis multiplex. They requested a few things. They said we need to do extended myositis panel, given the constitutional symptoms, the skin rash, the Gottron's, the mechanic's hand, the ILD, the myositis. Let's get that done. They wanted an MRI of the thighs and the shoulders to look for muscle edema, secondary to perhaps an inflammatory muscle syndrome. And they still wanted to rule out malignancy and a neoplastic sort of process. So they asked us to do a PET CT. I'll let you sort of dwell on that, and then the next Alcott will read the diagnosis and yeah, what happened essentially.
Go for it, Lera. What do you think?
Yeah, I'm just glad we're thinking in synchronicity with Pavandeep's team, and yeah, I don't have much to say actually, and I think this is an interesting thing that happened to me. First time that I've discussed cases that I don't actually have any additional thoughts.
Sorry, I'm muted again. I said that's because you thought of the arc a long, long time ago. The only way to silence Lyra is for her to have sniffed out the answer well before anticipated. I think Lyra, may I share another sort of like my job as somebody with more experience to just share with you yet another paradox. Patients with weight loss, the solution to their weight loss is often not cracked by doing an exam of extremities. Most of the time, people have weight loss, they have TB or cancer. And where is that TB or cancer? It's not in their extremities, it's in their viscera. And if I were to outline why this case is so challenging in real time, is because it's happening in another institution, difficult to reconcile the data. because when somebody's frail and cachectic, it's so easy to overlook proximal muscle weakness. It's also because most of the time, the center of gravity of a patient with weight loss is a radiographic entity in their chest and belly. Here, this disease is declaring itself on the surface in the skin with the characteristic signs of dermatomyositis. You will only find the answer to weight loss on the extremities in a very small number of people. This is a rare, rare, rare disease. And so I think, how could this suspicion have been made earlier? It's the moment you have underwhelming visceral imaging for a patient with weight loss. And I learned a lot from that, because when Pavandeep said, she just had some consolidation, her CT was largely negative, her CT abdomen was largely negative, I was like, ooh, where is this gonna go? And this case is teaching me that if I were ever in a situation in the future and somebody's truly losing weight, and I cannot obviously, it should be so obvious why somebody's losing weight with a CT chest, abdomen, pelvis. It may not be obvious as to what the cause is, but it's often obvious what lead to follow. Miliary nodules, large mass. You don't know what those are, but hey, I'm going there. When you scan somebody's chest, abdomen, pelvis, and you have no idea where to go, and they're losing weight, that's weird. That's really, 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 really weird. It's the exact opposite of Pavandeep's first case, where she presented a patient with a large liver lesion and some hematological abnormalities, and we were given so much to analyze. And here, in the exact mirror image of that, we've been given nothing to analyze except what? Ground glass opacities. So I think this is a beautiful illustration of how important it is to really study the extremities. Maybe not in the beginning, because base rate isn't there, but at least when the imaging is underwhelming. And I'm just seeing her muscles gone, her skin gone, I think, as a powerful clue. Now it's an academic exercise what inflammatory myositis she has. I think, just to emphasize the two, now that she's not amyopathic, the major category is antisynthetase syndrome. It is also a major category that causes a fever. Most inflammatory myositis are not febrile. And antisynthetase is the exception to the presence of objective fevers. And so that's an interesting twist there. Did any thoughts or questions come to your mind, Lera, before we hear from Pavandeep?
Yeah, I have another question. Hearing you speaking about this, like diffuse extremities and core pathologies, I have a question. Would you go looking for and tumor again in this patient, given the possibility of paraneoplastic syndrome and potentially like excessive disproportional inflammation and the havoc that the disease is doing to the patient?
Absolutely. Yeah, precisely. I think for any patient with inflammatory myositis, you have to go looking for a tumor. It is true, just to be honest, that most of the time the tumor for an inflammatory myositis is not metastatic. It's usually a localized tumor with a disproportionate paraneoplastic signature. And so if somebody's losing weight in this context, the tumor is probably not a big component of the weight loss. So here, if I'm looking for a tumor, it's often a hidden tumor that's camouflaged by the dominant paraneoplastic consequences it's having. The rate of cancers in antisynthetase syndrome specifically are actually on the lower end, compared not to the general population, which is higher, but compared to other inflammatory myositis like NXP2 and TIF gamma. So I think odds are that this patient, with her chest imaging being okay and her prior imaging being okay, that she'll probably be okay, but I think you have to look for sure. Yeah.
Thanks so much.
Of course. Pavandeep, you've enlightened us so much. What final aliquot do you have in store for us?
So we're nearly there, and you've done so well. So the MRI came back, said patchy high signal intensity change within the adductor muscle groups and the gluteus musculature. And then we also did an echo. So the room wanted an echo as well. There's mild to moderate TR. And the RVSP is 48, so high echocardiographic probability of pulmonary hypertension. There's no vegetations, and the rest of the echo was fine. So the extended myositis panel came back, and the only positive marker from there was the anti-MDA5 is positive. So given the ground glass opacities, the MRI showing patchy signal intensity in the muscle groups, the echo showing pulmonary hypertension, the rapid decline in her respiratory function, and ultimately a positive anti-MDA5. The diagnosis is anti-MDA5 inflammatory myositis in this patient. Yeah.
I'm doing it again. I can tell now by your body language. Oh, sorry. Pamani, maybe I'm really curious to get Lera's reflections. Maybe you can tell us what your experience was like, and also if you know how the patient did.
Yeah, so it was really tricky because I wasn't her parent team looking after her. I was just getting called to review this patient with fever, and I found it such a difficult dichotomy of like not being able to understand a patient's illness and the ailment. So her ailment being a fever and not really able to define an illness to able to sort of thread the ailment to the illness. And that was a really challenging part of it. And I think it's just sort of emphasizing you but guys did it beautifully, but like really honing in on what stands out the most. And the importance of terminology. Then when the room came and said, "Oh, it's got transpapules, and we can see a halter rash, and we can see the shore sign," that just triggers buzzwords in your head because that's what you're used to in the textbook, and it just shows the importance of being able to define things clearly. And I'm still trying to refine my understanding of that and hopefully just get better. But yeah, in terms of how this patient's doing, she's doing really well. So Room started her on prednisolone and she's on a tapering scheme. And she's also started on cyclophosphamide. And her swelling got better. We removed the NG. Salt came to see her. She's trialing free fluids and all that sort of stuff. So yeah, she got really better, and it was so nice to see.
Bobby, I didn't realize that you weren't directly responsible for her care, and so I'm even more grateful that you brought such rich learning to us today. I will just emphasize that when you hear a rheumatologist use cyclophosphamide, that's code word for them telling you they treat this as strongly as they possibly can. Cyclophosphamide is the top of the top in terms of potency and side effect profile of immunosuppression. So I think. I'm so glad that they caught her in the nick of time and that she's doing well. Lera, what are your reflections?
My biggest reflection is that I'm such a big fan of Pavandeep and her storytelling that, yeah, consider me a fan forever.
I second that. Count me in on that train. I think we're both about to be fans of Sana's teaching points. Take it away, Sana.
So initially, the patient presented with symptoms of septic shock. And before we reach the diagnosis, we always have to remember that we have to stabilize the patient first. And then, according to the symptoms, we discussed that it could be an acute infection that is progressing to a more septic picture with an underlying subacute inflammatory process going on, in which case we prioritize infections, autoimmune conditions, or malignancies. And then Dr. Rabi taught us that weight loss is usually a multifocal radiologically positive disease process. So it could either be an infection or a metastatic cancer. After the history of the patient, we have to consider their vulnerabilities like their endemicity, their occupation as a farmer, which could predispose them to certain infections, and the presence of recurrent inflammatory chest syndrome, which is not resolving. So, is this the wrong diagnosis or the wrong treatment? Then in the CT, we saw that there were bilateral diffuse ground glass opacities in both the lungs. So, when approaching ground glass opacities, they're usually indicative of a mild inflammatory process. And yeah, I don't have much else to add.
Oh, Sana, that is awesome. I was wondering how the ground glass opacities part is going to go because it's such a complicated concept. But I think you said it quite well, I'd say. It is a mild inflammatory disease process. And so the thing that I think all of us should go read about after the session is how can a marker of a mild inflammatory disease process cause so much illness in the patient? And I think that's very, very narrow differential diagnosis and one of the like three or four entities is MDA5 dermatomyositis. Awesome job. And yeah, I think we all have a lot of learning to do. This will definitely be an internal academy session that we'll try to reflect on and fine tune. Thank you, Mohammed, for scribing. Thank you, Pavandeep, for such an awesome case. And Lera, kudos to you for such an excellent discussion. Thanks, everyone. Have a great rest of your day.